Lastly, it is my proud privilege to invite on stage Dr. Gautam Das sir, a true pioneer in the field of pain medicine in India. Through his visionary leadership, tireless dedication, and passion for teaching, he has not only advanced the science of pain management, but also has inspired and mentored countless physicians across the country and worldwide. So please grace the occasion. I invite sir to moderate this session. Thank you, sir.
Good afternoon, post-lunch session. So we kept it intentional in the post-lunch session so that there will be no boring academic session. So we'll be discussing something, whatever we are doing, or we'll be doing for these 2 days or 3 days. So here, most of them who are sitting here, everybody knows they're exclusive pain practitioners in India who are basically, what was announced that they have inspired lots of pain physicians who are practicing pain. So I'll be just asking some of the questions, and let me start with Krishna, President of ISSP. Okay. So my question is that why you was inspired to be a pain physician rather than becoming well-known anesthesia practitioner?
So if I repeat my history, credit goes to you also, Gautam. If I really say, most of the people know it, but I was really very good and top anesthesia practice. He knows. So he came one day and I was doing some regional anesthesia conference, labor anesthesia. That was also not very common here in Calcutta. I was the first who was doing labor anesthesia and doing the workshop. He came, Krishna, I'm Dr. Das, there is some chronic pain. I saw him like, what? Means I don't know, I'm not interested actually, because I told, I think same sentence, I'm not interested, Gautam, because I was not thinking for anything other than anesthesia. I was so busy. I was doing labor anesthesia, but I was so busy. Then he said, Dekho, is done by the others and all this thing, and it is the future of anesthesia. Phir bola, okay, we'll do one conference. Okay, I say one conference. That I'm happily, because maybe it's my one of the hobby doing. Okay, I will do conference. That is okay to me. And he called. I heard the lecture by Dr. Dureja, and that day I was bit known about the pain. It is 2004. It is 2004. So I heard. Then I went to my hospital. I said, we do the pain, chronic pain. If any patient you have, tell me. And I was so excited. So one of the urologists told me, okay, I have one very bad cancer patient, Krishna, if you can do anything. I just give an epidural, what I am used to do. I saw he's having pain. I called him, I done the epidural. And after giving epidural, I given the pump, elastometric pump with the local anesthetic and fentanyl. Next day, believe me, in hospital, 10 people came to me, party of that patient. And he was just, madam, yesterday my brother or my son, he slept without pain. For so many days, he couldn't sleep, so pain. I thought, I give cases in anesthesia where patient has 20% ejection fraction. It is not done by any anesthetist. He came long way, and next day surgeon came with the sweets. Krishna, for you, because you done the case. Otherwise, I cannot do the lap chole without you in the 20% of the ejection. But party didn't know me. They never came to me saying, thank you, doctor, you have done my anesthesia so that my surgeon operated. But here I have done same thing, epidural. Then I got interested. Then I said, Gautam, I am coming to you. We'll learn. Then we started here, our state branch, living. Dr. Bibu Kalani Das is so great. She also helped us.
Thank you for sharing.
So it is my journey to be pain physician from the anesthesia, totally pure anesthesiologist to pure pain.
Okay, I'll be asking the same question to all the panelists. So get ready what you are going to answer.
So my journey is also like as Madam said. So I was also an anesthetist, and when I working as an anesthetist, so actually my my interest before taking anesthesia was orthopedics. I always wanted to be an orthopedic surgeon, but I was in army and I couldn't make it in orthopedics. So I took this anesthesiology, and after doing some anesthesia work, then my interest started delving into the critical care. Then I shifted to the critical care. But in critical care, same thing happened as madam said. There we are doing everything, right? In critical care, how do we manage patients, critical patients? But at the end of the day, a MD medicine who comes and he takes all the credit, everything, right? So I thought this is not a good thing to do. So I should have my own patients. This is where I started thinking 2005, 2006. So that time I decided I should go into the pain medicine, because that time it was very new and it was just coming up. We used to hear that, yes, in USA it is doing wonderful. In UK they are doing wonderful job in pain medicine. So that was the time I decided I should have my own patient, and then I started shifting towards the pain medicine. So this is how I started pain medicine.
So, but the question is basically still you started 20 years back, you, Krishna, most of you, but still the anesthesiologists have this question: shall I be able to sustain? If I am doing pain, shall I be able to sustain? So what is your suggestion or advice to the
Yeah, definitely this was the question that time also. 20 years back also this was there. And I'm sure that most of us, we left our anesthesia practice, a roaring practice in a good setups. We were working in a very big setups. And we left that time. And I'm talking about 20 years back, when there was almost nothing. There's no backup to us also. But now we should not be worried. The youngsters, they should not be worried, because they have a lot of opportunities. They have a lot of opportunity to learn the techniques. And especially, you have backup also. You have a lot of senior pain physicians who are there to support you. So financial wise, I don't think it is a big issue now, because most of the procedures are also covered under insurance. And if I tell you about Delhi, especially, I tell you, in Delhi, we have all the corporate hospitals, we have a pain departments here. Now the corporates, they are calling people. They are looking for the people to start a pain department. Why they are doing this? Why corporates are going into this thing? Because they are seeing a huge revenues coming out of the pain medicine departments. So the revenue is not an issue now. And employment is not an issue.
So our struggle was much more than who are
Much more. Much more.
So Gaurav joined late. So Gaurav was discussing that why you people, you all are stalwarts. So why you have started or chosen pain as a leaving the easy, well-known anesthesia practice, or majority times you all people are giving in the pain. Why? Which actually attracted towards this specialty?
The main reason is that we are the master of ourselves, our work, and we want to put a place in clinical practice and the society so that we can help directly to the patient. In anesthesia, we don't have the control over the patient. Yes, or only clinical part. But in the society, you have to, actually you should be helpful to the society per se, that yes, directly you can give the benefits.
Means direct contact with the patients.
Direct contact with the patients.
And appreciation from the patient.
Yes, appreciation for the patient.
Okay. So now, Karthik, your view. How you started your journey and why?
4 points. 4 points. Recognition, no dependence, no night duties. Couldn't stand the obstetricians.
Okay, so short and crispy answer. Madhan.
Probably I'll be having the longest journey and the answer, but thing is, I wondered why I was placed as an expert here. I don't belong to this league, probably. Like, anyway, means like it's a difficult story. It's always a difficult story to tell, like when 2018 Jammu ICRA, means like I still remember all the conferences in pain medicine used to be like this actually. 3:30 there used to be a panel discussion on day 3 when everybody used to go for the flights, and we will be discussing, and Karthik will be roaring at me. What best you can do with ultrasound. So I think I had the answer today, 2025, we have the answer. The theme of the conference is MSK, right? So I started in 2012 when I came to Dr. Das. He was my guide, okay? And he was my college junior in MD. Means like much senior in pain though. So I called him up one day. I said like, see Karthik, I wanted to do something which is self-reliant, as he said rightly. So when I said this, like he said, Madan, I think it won't suit your things. You need to have your clinic, patients. He knows my temperament. I'm temperamentally not that. I say white is white and black is black. So that's the way I go it. So he said like, Madan, this may not be right actually. So I've done my fellowship. I have gone through a lot of things. So doing at this age may not be that easy. So I started probably like now I'm 49 plus. So you can imagine like 13 years back. So it's a bit late I started with. But definitely I took a tool called ultrasound. The moment I left Dr. Das after 15 days, I knew that I'm not going to take a fluoroscopy any further. So for fear of something, my father was a cancer patient, so I had some fear of malignancies and things. So I just started doing ultrasound. But those were days, 2012 days, ultrasound was nowhere in the picture. Nowhere in the picture, but when I started posting on my social media posts and things, people used to laugh. I kept on doing that, same mistakes. Wanted more critics to come in. A lot of people came in, a lot of people advised. I keep disclosing this anywhere in any conference. I have never gone in for any structured program in pain medicine, not even for ultrasound. But it's all about learning on myself, that which gave me the strength. Went about little slowly, steadily, but very clearly at 2018, I decided I should give it back to the society. It is not just about learning by yourself. You should spread the knowledge. Unless you spread, probably in 2025, I would not see this much big crowd for MSK. So that is what I did. And very clearly, after 2022, post-COVID, we had a group of like-minded people coming up. We wanted to start our own society. Starting a MUPS society was probably the greatest moment, I would say. Then after, we slowly went into teaching more. And now, even though the radiology forum has actually said like no entry for us into the radiology conferences, they don't want to teach us as well. So still, I think like we are self-sufficient and self-reliant in teaching our own community. So that's probably the success which I wouldn't say own, I would share with other people.
Okay, so Anand, please.
So the necessity is the mother of invention, they say. Like the journey again started as an anesthesiologist only, but predominantly I was doing an orthopedic anesthesia work. We know like the role of regional anesthesia is more in orthopedic surgery for the post-op pain management. So when I was practicing orthopedic anesthesia at that time, like, you know, the post-operative analgesic regime is tramadol and tramadol infusion. And with the patient, one side pain, another side patient throwing up, and then it makes their life miserable with, you know, the opioid, and that too tramadol, we all know about it now. So then when I want to deep dive into it, like how to make the patient's post-operative situation better. So then, you know, sort of started doing this psoas compartment block for hip replacement surgery and femoral blocks and saphenous nerve blocks. That made a lot of difference. Then I realized the key, the opioid sparing key. The opioid sparing key is the one that actually transformed me. So like for me, it's like a chain of event. Then, okay, I thought like, let me not just stop with only the acute regional pain services. We need to do something in chronic pain. Again, like we all discuss about the opioid sparing advantage of our interventional pain. So that actually led me to go into the chronic pain and learn. I first started my learning from Dr. Dureja in 2010. I still want to mention one point. After I come back, like I was given a responsibility by a national neuro trust. It's a national conference on neurology, happened in Chennai. So they asked me to conduct one chronic pain conference there. I was literally flabbergasted, like, you know, I was so new in chronic pain, just 1 year over. So how am I going to do this chronic pain workshop? This I'm talking about 2009. Then I spoke to Dr. Das, and then, you know, he was so busy that time with a lot of his commitments and everything. But even then, one phone call, he agreed to come. And then that's a very interesting situation that particular day, I think he skipped the flight and then he came little late. Then there was no time because the audience were waiting. Then we took him in our train, the electric train. So, and then in last minute we went there and then we conducted that National Neuro Conference, the pain workshop. So, these are all cascading, like, you do something, like after that the visibility increases and the persistence, like you keep doing the same thing, not deviating from that, and then each time you do that, it cascade. Then somebody else will come to know, okay, he's doing so and so. So then with that visibility, you can expand your practice, or your expertise increases, and that is how it has taken me to US for my training in chronic pain. Then I went to Toronto Western Hospital for my ultrasound training there. So it just started from there. And the most important question what Dr. Das is asking, like about, can we sustain only in pain? Actually, yes. Because when we started, it was not like that, because people are telling me, what is there to learn in pain? It's all about epidural. You can make the patient sit and then give the epidural. That's what is all about pain. Then why you need a special training for that to go and then, excel in that field? But it has transformed so much now, it has become, it's evolved as a science now. And thanks to mentor like Dr. Das and Dr. Daradia and so many. And this has created a very big platform. And even now surgeons, they don't want to do any of the chronic pain, to be very honest, because I'm working in a corporate hospital where most of you feel there is no generosity from the surgeons to share their patients. No, it's not like that. They also feel so much threatened about the medical legality now, and with the evidence-based practice, they just want their patient to get better, and we are getting a lot of references from our fellow surgical colleagues. So there is a tremendous scope for the pain enthusiasts to take up this branch, even from day one, and they can still sustain well. That is my takes.
Thank you. Same question to Dr. Sunita as well.
Yeah, thank you. I was associate professor in medical college, and my professor asked me, there is one conference at Ahmedabad, why don't you present one paper out there? As such, many orthopedicians, it was a government medical college, so they used to send patients. I was very much interested in giving epidurals, only that was there, along with regional blocks. So I said, okay, I'll present this same thing. And I went, that was my first conference in 2006, and I really was so much interested that there is something else apart from anesthesia, where there is existence, and I will have my independence, because going into private practice was not my cup of tea. Being a female looking after house, we all know the problems. So then I really got interested, and then I left my job. I was about to become a professor, but then I said, no, nothing, this is nothing, something is lacking, something is there which I want. Then I thought, shall I go for critical care? What Pankaj said, same thing. Critical care or pain. And then I said nothing, I'll go for pain, and the journey started. It was really very difficult for us to survive because there were no classes and no workshops, only Dr. Das and Dr. Daradia. At Daradia doctor's place, there was 6 months waiting period. So so we had to struggle a lot. For only one case, we had to go and see it, read. So this is how it started. And I will say I'm very happy today, fully contented, independent, and we have our own existence. So don't be scared. This is what I want to convey. Yes, it takes time, but then the journey definitely will take you to your wishes, where you want to be. Thank you.
Okay, so thank you very much. I'm sure everybody enjoyed the journey, maybe inspired what they are thinking, and it's possible to sustain. They all people could sustain, so you people also can sustain in practice. Now, very interesting part, what I'll be asking to all of you. You have to share one of the very bad day, black day, or the day which the memory is not pleasant. Whenever you are thinking of that day, you are always feeling, awkward, bitter. But definitely, every bitter experience of us teaches us something. Teaches to be a better person, maybe a better human being, maybe better service to the patient, whatever might be. So every bitterness in our life have some great teaching in our life. So your teaching, I always, this is my favorite dialogue I can say. that the mistake what I did, my fellows should not do that same mistake. They are also prone to, because we all are human beings. The mistake what I did, everyone else as a human being are supposed to do the similar kind of mistake. But if they are learning, they are becoming starting from a point where we are actually transferring our knowledge that, okay, we did this mistake, you people should not do. So please, all of you, I'll be asking, there might be a lot of such mistake. At least if I am starting telling my mistake, it might be the whole day that, okay, I'm just going to tell my mistakes. So please, one very important mistake or black day or a day, bitter day you want to forget, and you learned a important lesson, please, all of you, just think and share one of such bitter experiences. Who will start? Others might be thinking. If somebody is ready, can start. And others might be thinking, which one is the most bitter experience?
The common thing which I normally do is a shoulder. So generally, like when I do a shoulder, I always position the patient on the lateral side, try to convince myself for the ergonomics which I need. So literally like leaving the patient, rather like patient sometimes going from the, will be facing the wall, and lot of times I have seen patients landing up with vasovagal syncope, and the moment you turn the patient this side, almost unresponsive patients I have seen. So not just one, a lot of patients, around 20% of my patients were there like that. So what I decided to go for is, only patients will be facing only towards you, and lateral to medial needling, never go from medial to lateral, and ensure that you keep talking to the patient and give some time gap between the injection and the mobilization. So this is number one. Number two, with respect to carpal tunnels, there was a dentist who was actually showing her hand. Usually I started doing all my carpal tunnels with the patient in the sitting position. So I was just showing her, she being a doctor, actually the husband is also a dentist, she is also a dentist. So I was trying to show them, I have a slave monitor. So I enjoy scanning as usual. I was showing them the needle, all that, everything. The needle looked very big for her. The moment she saw the needle, she fainted. She didn't faint actually, she went into asystole. For a carpal tunnel, a seemingly simple intervention with local anesthetic, with a 26 gauge needle, I normally choose only 26 gauge needle, she went into asystole. In my clinic, at the intervention site, I resuscitated her. That's a different story altogether. A seemingly simple intervention without monitoring what can go wrong. This is what can go wrong. She vomited, she passed stools, she became apneic. So the kind of resuscitation equipments and facilities which you should have, luckily it was a good anesthetist clinic. I always had my laryngoscope, my tube, ambu bag, cylinders, everything were in place. But see how difficult it will be even for a simple procedure like a carpal tunnel injection, right? The third one, of course, I'll limit to another 30 seconds. I did a pyriformis injection. After the pyriformis injection, the patient, I started him to ask, walk. He had a foot drop. So probably I had gone somewhere close to the sciatic nerve. I have given a sciatic nerve injection. Normally I choose injection volumes based on what is given in Samir Noros. Very standard volumes. 1 ml plus 1 ml, 1 ml plus 1 ml. That's all. I don't go beyond that actually. So I had given hardly 1 ml of 2% lignocaine. The only thing is I gave 2% lignocaine. So 20 milligrams of triamcinolone, that is hexacetonide. So 1 ml plus 1 ml. Given to it, the patient had a foot drop. So normally I do my procedures in the evening. So it was around say 8 o'clock and 9 o'clock he was not recovering. I was expecting the lignocaine to work only for 45 minutes. It didn't happen. So I got him to a nearby hospital. I admitted him. Basically see how it happens actually. Slowly things evolve. There is nothing, like no recovery. Patient starts getting more anxious. You get more anxious. No one to help you in the night. Whether to do any other investigation, any other, whatever be the amount of reassurance which you give, it's not working. Next day morning, 5 o'clock, I call up the neurologist, neurosurgeon, everybody, still the foot drop is there. So I didn't know what to do. So kept on calling people, gave a methylprednisolone, antibiotic, painkiller, everything. One thing which I understood that day was not to give too many things except for reassuring yourself. Not just the patient, by yourself. So by 2 o'clock, I took an appointment for an MRI just to see if there is anything which I did to the nerve or if there is any other pathology which I missed. But once he went in the MRI suit, after 45 minutes, he comes back walking. So there was no problem with that, but I still don't know the reason why it acted for so many, means nearly 48 hours, 16, 18 hours it worked. And for a 1 ml of volume, it is probably little too much actually. But I'm not sure why that actually acted for this many times. So these were my experiences, but luckily, like God's grace, nothing more than this has happened.
So thank you so much, Madan. I'm sure that the bitter days has a lot of things to learn. Thank you. Okay, Dr. Madan.
I want to
Anand.
share one interesting, I'm sure it will be very interesting for all of you also to hear. See, I'm working in a corporate hospital, so one of the patient is she's a cancer survivor. So I posted for a shoulder intervention, and of course I'll be having all the time 1 or 2 fellows, like I keep talking when I do the procedure. That patient was a little unaffordable. They had spent a lot of money in cancer treatment and chemos and everything. So, and she was in a severe agonal pain. I thought I should help her. So the procedure went on well, and I didn't charge the patient. I didn't charge the patient because I really wanted to help, because cancer survivor exhausted with funds. Next day I got a call from the medical superintendent of the hospital saying that you got the complaint from this patient. The complaint is so funny, like patient got the relief, but the patient said, I have been used as a clinical material. And then the doctor was explaining about my particular condition to their so many people there in the theater, and I can tell you, because he did not charge, he did not bill me, so it is apparently very clear that he has utilized me as a clinical material. So I realized one thing: never do anything
Have
free
he
of cost.
used the term guinea pig?
Yeah, yes, of course.
Sometimes
Yes.
people use that term as well.
Yeah, but actually speaking, I always introduce the patient whenever they come to the theater that this is my team. But I realized that it's my biggest mistake. It's not about money, like at least some amount of fees, I think, or the charges you should make. That's my personal opinion, because I felt so bad that day. My gesture was taken in a different direction. I did it free for her, but it was misunderstood, saying he didn't charge for me because like he has utilized it as a material. So I realized that day, like, no more treating patients free. At least you have to charge in 100 rupees or 1000 rupees or 2000 rupees. So I really felt bad that day. That is one. And the second one I felt regret is, like, I started my clinical practice long back actually. 2009, I went to Dr. Daradia, and then I came back and I was so persistent in my practice. But I was never into the academic activity till 2018. So it was 10 years of my, in fact, Dr. Poddar and everybody were asking, like, you are doing a good job, but you are not attending any conferences, you are not sharing. Actually, I felt, now I feel like it's a big mistake. So what you learn, you should teach others. So which I didn't do for 10 years, I started doing after 2018. That's another thing I felt very bad.
Thank you. Who next is going to share?
Me.
Okay, Gaurav.
Just when you are starting that bitter incidents, so there are a series of events is coming to the mind. So we just in mind we are choosing which should be shared, which should not be shared. So they are just like Dr. Madhan has shared that in his clinical setup he has gone patient into assist. So 2 or 3 patients of ours also gone to such places. I have been attached to government as well as in private practice also. So in government setup, we don't, because anesthesia people usually they don't cooperate. You are being a junior or just to go to there and yeah. So how we started that, yes, एक कोने में जहाँ पर कोई PAC room है या उसमें घुस के आप कुछ procedure कर रहे हो तो simple trigger point injection and simple what you can do. At there are 2 or 3 incidents like him only. So that's how we learned the lesson. Don't do anything small intervention in that. You have to be in OT with proper setup and proper backup. So that's the one lesson which I shared with Dr. Same with the Dr. Madhan. Another is that money. There are 2 or 3 incidents in the initial practice when I started my practice. So we used to little bit of defensive because you are also not in very full command or full confident voice.
And
so
not sure what is going to happen.
what about
Not
the
sure
effect
about the
also.
result.
So there was one NRI patient, NRI software engineer came from US, and he came at Jaipur and he took one year back some intervention at Dr. Daradia place, Delhi. And after that, because he belongs to Rajasthan, so he inquired that who is doing practice. So some big neurologist, he suggested my name. Then I took that call, and I asked him to come at my place at home, because at that time 2 or 3 there are centers, but he insisted, "Nahi, I want to come at your home." So I took the consultation at my home, and I explained the procedures and all these things, and about the charges, because that's the most important thing, how you should be able to express about your charges. That the same thing जो charges के बात हुई, तो so I could not make me comfortable in asking. He said, "How much, doctor?" So I know that it should be around 20,000 or 15,000, and ultimately it was being bargained, and he bargain was happened at the last 750 rupees. Can you imagine? 750 rupees. I was so disappointed and depressed with myself that I could not ask proper money for them. And that to a very well-educated, person who is known of the pain medicine. So because he took the treatment in US and in India also, but that was a very distressing moment. That was a very bitter memory. Another thing is,
so what is your advice?
You should
your
charge
your
good
suggestions?
amount. You should charge your consultation, and if you are. That was very depressing for 1 month, and then the lesson learned, जैसे तीसरी कसम में राज कपूर कसम खाता है कि घर पे मरीज नहीं देखूंगा कभी भी, है ना. It should be at proper setup, and it has to be with some, आपका वहाँ पे बाहर बैठा होना चाहिए आपका रिसेप्शनिस्ट, एंड अगर कोई फ्री भी करना है तो पहले फ्री 0 रुपीज़ की रसीद कटेगी, तो उसके बाद तक, so that patient can understand that what they are getting in free. This is the practice which I followed. Another one is, जैसे ही पैसे के लिए एक और मैं बात बताऊँ, एक पीपल दे यूज टू, यार ये करता है, कुछ करता है, पता नहीं क्या करता है ना. तो साहब, देयर इज वन पेशेंट इन आवर कॉर्पोरेट से वो डिस्चार्ज लेके आई, द यंग फीमेल, इट्स अराउंड 2014-15. तो यंग फीमेल पेशेंट, इट वाज 20 years, सो आई वाज कॉल्ड अपॉन दैट हॉस्पिटल. तो ही वाज ओन्ड बाय अ डॉक्टर, फिजिशियन एंड गायनेकोलॉजी कॉम्बो. सो यार हमने तो सब कुछ करके देख लिया, अब इसको एब्डोमिनल पेन है, नाउ व्हाट विल सजेस्ट. आई पुट दैट सारा उसका रिकॉर्ड, तो उसका सारा पिछले 7 दिन में उसका 4.5 लाख रुपए का बिल बन चुका था. 4.5 lakhs ऑलरेडी स्पेंट. 4.5 lakhs rupees already spent, and there is no diagnosis has been made. Abdominal pain, severe abdominal pain, she couldn't move, she's very, or she's weeping like that. So on examination I found that anterior cutaneous entrapment acne. So clinical examination I just put, मैंने कहा ठीक है ये लो OT में मैं इसको कर देता हूँ. Again that मैंने procedure किया, patient got relieved, immediate relieved. So when I asked about the charges, तो उसने मेरे से पूछा भी नहीं डॉक्टर ने. He tell me, okay 500 रुपीज़ दे देते हैं तेरे को यार. अरे मैंने कहा यार भैया ये डायग्नोसिस भी तुम नहीं बना सकते ना, डायग्नोसिस तो मेरा, तो मैंने यहाँ पर आके, तो तुम्हारे यहाँ से मैं गाड़ी लेके तुम्हारे हॉस्पिटल में, सॉरी. सो आई वेंट टू योर हॉस्पिटल, आई एम ऑन योर कंसल्टेशन, एंड देन आई पुट, आई examined, I made a diagnosis which is not very common at that time. It is not had been discussed. मैंने कहा कि आप पूरे शहर में you will roam around in a whole city, and if anybody can make this diagnosis, then I will. So, but that physician and that couple has so adamant. So I have sorry. मैंने कहा I don't want to 500 rupees also. So that's the message is कि you should able to ask money. You should be very confident. These are the things which made us stronger. Now अब पैसे मांगने में मतलब आपको जोर नहीं आता. You should be very clear how much money you should ask. That is the important thing. Another.
So there are a lot of, I think how you inspire or how you start is the less inspiring, but we have lot of things to say ki what mistake we have done, how we learned. Because, I will do only 2 cases. One case, initially 2005-6, as everyone know, we don't have the YouTube, we didn't have the Google. And Dr. Dureja, when I did the training, he has given me, Xerox, Raj's practical book, Xerox only, not the original, which has the only black and white. So I used to, open, I was doing one celiac for the very big cancer and very big, and oncologist referred me. I was so happy, I am doing celiac and alcohol. And I used to open the book and step by step, and I used to say, technician को देखो ठीक है ना, ये ऐसा फोटो है ना, एक्सरे का फोटो is same as I am seeing in the book. हाँ मैडम ठीक है, next. So I was doing that way, and I was giving alcohol after putting the needle, and patient say, in Bengali, আমার তো পেচ্ছাপ হয়ে যাচ্ছে. I mean, I am not having control over the urine. I thought I have not done anything to urine. Why the urine come? Why she is not having? And after that I saw she is the paralytic. Both. Of course we referred, but my oncologist was good, as she has a very big tumor, and even in fact she has the bust, after that bust tumor. So he explained, he said, Dr. Poddar, don't worry. And it was big corporate hospital, Ruby Hospital. He said, don't worry, I'll explain. So I said, but I thought my procedure done the paralysis. When I was in, I called him, my one only ki, Gautam, paralysis happened, so he also counseled me, and what happened, I didn't have. But that was very initial. One more very important, which I actually learned, that was my mistake. I think maybe how it happened, still I don't know explanation, because that was my initial days. I started doing vertebroplasty, kyphoplasty. So normally the spine, few orthopedic surgeon and neurosurgeon used to call me, okay, Dr. Poddar, you do my patient, I used to do their patients. It was not my patient, their patient. One surgeon asked me, Krishna, I have put, Dr. Poddar, I have put one vertebroplasty, you come. So I saw only in the table. I did. And one side I was putting, one side he was putting cement. Both side I put the needle, but he was. And patient got leak, the cement leak. We called, of course, a spine surgeon. He opened, and he was very elderly. So that day only, because after that I saw there was bust and maybe there was a retropulsion. And that day I learned the lesson. Now I will not do any procedure for anyone's patient. I first see the patient, I will assess the patient, and then afterwards, whenever that surgeon referred me, I said, no, doctor, you can admit under you, but you refer me, I will see MRI, I'll see, and then I'll put the patient. That was, I think, my mistake doing the procedure.
Thank you, Krishna. The most important things, your courage, because majority of, if you are asking the consultants, very few people will be telling what their complications about their practice. Very, very few. So you are so honest and so courageous, yes, that you could share publicly about your hot complication you will end up.
Yeah, because
so big cap for you. Really, really, very, very few people will be openly share that mistake or complication I did. Thank you. But all these are basically giving us the lesson. Yes. This all could happen to our life as well, even if apparently we are done everything very right. Thank you.
Yeah.
Okay, Pankaj.
But
okay, so
never do, epidural for someone else patient. It should be your. That you should learn from the first day of the practice. Maybe you will lose 1 or 2 patients, but you will get the third patient.
Just examine the patient beforehand. That is it. So, yeah. So I started my spine endoscopy in 2014, immediately after doing 3 days of workshop in Germany. I came back to India in 3 days for attending workshop. I started doing spine endoscopy. My second case, complication, discitis. 4th case, failure. I couldn't enter. 6th case, again, discitis. So this was my first initial 6 cases. That time, because I did not have my own instruments, so I used to call a guy from outside. He used to bring the instruments, everything with him, and then I used to perform this procedure. So 6 procedures, after doing 6 procedures, that was actually the black days, I can say black years also. For almost 2 years, I was cursing myself, why did I do this? Just after learning 3 days of, attending 3 days of workshop, I started doing, and I had 3 complications. 2 complications plus one, in one case I couldn't do anything. So almost for 2 years, I stopped actually practicing. I started thinking that why I should enter into this field. That was the time when I actually stopped doing endoscopy. But I thought it's not a good idea to stop doing anything which is we have already learned, and it is a requirement at this moment, because if we stop doing these things, our youngsters who are going to come, they will won't be able to even start, right? So we cannot stop at this moment. So again I went to Korea. I went to Korea for 3 weeks. After coming from there, I purchased my own equipments. The first thing what I did was I purchased the entire set, entire equipment, the towers, instrument, everything I purchased myself. And then I started doing endoscopy regularly. And today, almost like, I can say almost, I'm the maximum number of endoscopies I'm doing in this northern India. Almost 15 to 20 I'm doing in a month. So basically what I want to say is that the mistake what I did was I started practicing a more invasive procedure by just attending a workshop, which was wrong on my part. So without adequate learning, I started doing this thing. Second, I was dependent on the instrument from outside. Investment is important. So invest in your own equipments. That is very, very important in your practice. That's an investment. Whatever you are investing in this, you will recover within maybe 6 to 10 cases is what is required to recover those kind of investment. So never ever start anything with just 2-3 days of workshop and invest in your own equipments. So complications at times teaches you lots of many things. And you, actually that basically gives you a break also, ki yes, you should stop here. You should start learning more. This is not a good idea to start practicing like this. Maybe that's it.
Thank you, Pankaj, for your beautiful lesson. I'm sure that everybody will be encouraged. So now, Tom.
So probably most of us would have done our mistakes in the early part of our career. We've all learned from them and then become better. So this is more a technical thing from my practice, pretty early in my practice. So I was working in the Apollo Pain Clinic in those days. So this was a pretty routine case is what I would call. So I'm reasonably comfortable in doing transforaminals, caudals, facet joint injections. Probably 40 to 50-year-old lady coming in with a bit of back pain and a bit of radicular pain. Now this radicular pain, the usual segments that you're going to find is more L5-S1 nerve root involvement. This lady had a disc-related lesion slightly higher up. So she had a L2-3 and an L3-4 disc, which was pretty bad. So there was bilateral nerve root compression, 3 levels. And this was quite an old injury, so there was facet involvement as well. So she's having, in my opinion at that time, L2-3, 3-4, 4-5, 3-level bilateral facet arthritis and nerve root impingement. Now, pretty routine case. So I thought if it was in the lower segment, I would have been inclined maybe to do a caudal epidural because both sides were involved. Along with it, a facet joint injection. I was planning probably an intra-articular cortisone shot for the facet. Now, because it was higher up, L2-3, 3-4, 4-5, I thought, okay, we'll do a normal interlaminar epidural, which would go in the midline and I would cover 3 or 4 segments. Along with that, the facet joint injection. So that was my plan. So routine case, everything is fixed. May I say one patient? So a patient is prone. I have my pulse ox. I have my BP. I've checked the BP. BP is okay. One small, an IV line is running and 500 ml is going in. So I thought maybe I'm going to give contrast for the interlaminar and I'm not going to give contrast for the facet. So I thought, okay, we'll do the interlaminar first and then we'll come to the facet. So I thought it was a routine case. So L2, 3, 3, 4, 4, 5. So I went in, patient is prone, 3-4 level interlaminar, and I thought I had a good give. The contrast looked satisfactory to me. I gave about 8 or 10 ml of local anesthetic with about 60 to 80 milligram of methylprednisolone. So the interlaminar was done. I thought I had good contrast spread. And then I was doing the facet joints. So facet joints I was doing intra-articular. So usually if I'm doing a 3 level, I'll put one needle, one level above, and then 3 levels, and then the other side. Now apparently, which I realized later, I had probably done an intrathecal, and this lady had a hypotension, which because I was doing a facet joint injection and the patient was prone, I had actually missed. So probably because of the interlaminar or the supposed intrathecal local anesthetic, she had a hypotension, and I didn't notice it, and I continued doing the facet joint, which probably took me about 10 minutes, and then by the time I had finished the procedure and turned it around, she was not responsive. She had a hypotension, of course. We did revive her. So some valuable lessons to learn there. So continuous monitoring is required. Talking to your patient throughout the procedure would be a good idea, and checking blood pressure almost like 3 minutes or 5 minutes after any epidural or interlaminar or caudal would be a good idea. So that's my lesson.
So thank you, Karthik. So I feel that, okay,
I am left, sir.
session could have been staged for the long, you know. Yes, we are coming to you. I know you are left.
He says he thought that I am past president, but it's not like that. I am a president is always president. May I, sir?
Yes.
This incidents happened, though it's a very small incidents, not very serious type what all have said, but see my negligence, and it caused in medical college, the fellow is there with us always because they want to learn, and nowadays what happens is orthopedic people, they also want to learn. So what their PGs will do, their seniors tell them, you stand behind and see what she's teaching them. So we will see and we'll do it. It's like that nowadays what is happening is, it's because they want to learn. So that day what happened, I did a block, patient was VVIP, some politicians relative. So the patient is VIP for every one of them. So everything was done, procedure done. After 4 hours, the fellow calls me. I went home. She tells me, ki, madam, patient is not moving the limb. I said, what? Ask, what, any motor thing is 0, motor power is 0. I said, how can this happen? It was L4-5 disc, and we gave our selective nerve root block, MIPSI, sorry, not block. And then after 4 hours also, when there was no movement, I thought, what must have happened? Then I asked her, what about the drugs? So she's, then I said, what was, I usually give Sensacane. So she said, madam, I said, what was the concentration? She said it was 0.5%. So usually we take 0.25 and we double dilute it. So this is something which made me, because I didn't see it there. I said, take 0.5 and double dilute it with steroid. But what happened was, it was 0.5 which was taken, not 0.25. And it was given at 2 level. So for that day, for around 6 to 8 hours, the patient was there. There was a lot of rush. I had to go see everything. And I told them, okay, next day he'll be okay. Sometimes it happens in 1% of patients. So because I knew what has happened. So this is a lesson which we should always see, even if fellows are there, that what concentration, even the drugs, which doesn't matter much, but then this can happen with anyone.
Thank you, Dr. Sunita. Because of the time, otherwise, you know, at least I am enjoying this session very much, and I'm sure that our audience is also enjoying. So I'll be asking one, not many, from audience, if they wish to share their mistake. Please stand and come, or we can give you the microphone, and we'll be very happy to hear if anyone wishes to share. Yes, Kasinath, please come. You can come here. Today is not my turn. If any conference, any one of you asking me and asking, sitting there and telling, okay, Dr. Das, please share your complication, that day I'll be telling. Or my bad day, that day I'll be telling. Okay.
So, first of all, thank you very much for inviting. The day or the patient or the complication, nobody wants. I had done that. And that is the death of the patient after meningitis, after a caudal epidural. So what happened is, patient of some malignancy, radiculopathy. Malignancy was not a reason for the pain, and I did a caudal epidural. 2 or 3 days after that, I received a call from the casualty that patient is having delirious, and he's come here for the admission. So I asked the casualty person, admit the patient and get the test done, neurologist opinion done. I rushed there, asked for the LP. Obviously, there was neck rigidity and all other factors. LP was done. It was a pus into the CSF. Worst thing, a lot of fight, medical fight. The patient died. Then we sit and we started retrospectively thinking, what could have been gone so wrong that the thing which nobody wants and I have witnessed that. So ours is a urology hospital. The main work in the hospital is urology, right? I'll explain you what happens and how a lesson is learned. So there is a contrast, and it is a vial we use for the contrast. And when the person takes the contrast, there's a lot of habits. So you took 10 ml, you give the contrast, and you want to take another 10 ml. Now what the brother will do is, so you are giving it into the urological system, some RIRS, URS, and what happens is, the same syringe is taken, air is filled into that syringe, maybe some contamination is already there, there must be pyelonephritis or whatever, you push the air inside, and then you put up the contrast, okay? This is the contrast. Next day what happens? We go to the next case, and we use the same contrast. You understood? From that day onwards, none of me, none of my fellow, or none of any staff from the hospital where I work is allowed to reuse any of the drug for any of the case. And the consequence is he will get worstly fire of his life. And this has happened 2-3 times. No, now the people know me that, okay. So money doesn't matter for me. Or that for that matter, it doesn't matter for anybody. It doesn't cost everything you take a new, and it will not cost more than 1,000 to 1,500. And contrast vials are, ampules of the contrast are available, water-soluble contrast. So the biggest lesson learned is, for every patient, single-use drugs has to be used. Doesn't matter what happens. Thank you, sir.
Thank you, Kasinath. So we'll be ending the session, but before that, I want to, one funny incident. I remember we was one of the conference, and I heard this from Gaurav, and I'll be asking Gaurav to share that before we are ending this with a little bit of humor. And but again, I'll be asking that, okay, some part of it must be in Hindi, otherwise you'll not be able to get that, this. But still, try to be as much as possible in English.
So, actually, there are a lot of incidents, but sir has already, he remembered that incidents because we have learned that we should be in our hospital setup, our OPD should be, setup is like that. Nowadays, with our experience, I have the CCTV camera in my OPD consultation room with the whole microphone facilities also. So that is the one lesson which I have learned over the years, because it has saved me at least 6 or 7 times to get sued. Because I already said, there are fixed dialogues which I used to convince the patients and attendants. So there are multiple episodes. So one episode which I've sir mentioned, which I should share with you, that It's a very common practice. Patient comes to you, sir, I have pain this, and 6 months ho gaye, 6 months, 1 year. I'm so much worried. Please help me. Okay, so we used to counsel. Yes, there is a myofascial is there, or something is like there. So you should have taken for pharmaceutical treatment, pharmacological treatment. Then if needed, then we can. Oh no, sir, pharma. I don't like allopathy drugs. Allopathy is too much side effect. I don't, it's not my cup of tea, please. Okay, so, then we can help you by some exercise or lifestyle modification. I have already done. I'm going into the gym and I do the Zumbas and all these things. Okay, then another option, if you want to have, then we can go for intervention. These are some small intervention. If it is not working, then we can go some little bit more invasive intervention. Intervention? Sui? No, doctor. I don't want to go into any intervention. No. Okay, then please come near. I should ask something else. I have one more options for you. Yes, please come. Okay. तो हम हिंदी में बोलते हैं अपना कान लाओ पास में. Put I want your ear to be so. Yes sir. So I was just okay. I will whistle. Why? मैंने कहा मैं फूंक मार देता हूँ कान में और तो क्या कर सकता हूँ. This is a so this is and उससे पहले क्या I was very depressed मतलब embarrassed. मैंने कि क्या बोले मतलब it's every third or fourth patient is like that. No, I don't needle is I don't want to do and allopathy I don't. That day I got the answer. Nowadays any patient comes, come near me. I will give you the treatment. And I have broom also. अगर झाड़ू से भी मैं हवा कर दूंगा उससे भी जाएगा. और दूसरा मैंने सर आप मजाक कर रहे हैं तो मैंने मजाक तुम आए मेरे पास ट्रीटमेंट कराने हो. When you are coming to the doctor and I am an allopathy doctor, I am a pain physician. I will give you other pain prediction or pain treatment. Why did you come? So okay, I got my consultation. I will advise you the treatment. पास आओ फूंक मारूंगा. Thank you very much.
गौरव धुनी वाले बाबा बन गए तुम.
So thank you very much. Thank you all the experts. And I am sure that all of you have enjoyed this session. And we'll be having the similar kind of sessions somewhere in some other conferences. Thank you very much.